Well, thank you very much. Thanks for the invitation to come and join. It's always nice to be a heart failure person at an interventional conference. The only time I've been more intimidated was when I spoke to a room full of surgeons about medical treatment of mitral regurgitation. Nobody smiled at that conference, and I just want to congratulate the interventional team. Those are two phenomenal cases, and it really was a pleasure for me to watch that and to watch the expert care, the multidisciplinary care that delivers great outcomes to our patients. So I'm going to change the subject a little bit, talk about the role of medical therapy and intervention in treating secondary mitral regurgitation. I hope to leave you with some practical guidance about when you know that medical therapy is optimized, because oftentimes we can't get to maximal doses. So this is a reason why heart failure cardiologists are not invited at interventional structural meetings, because we love to talk about pressure volume loops. And for us, it really centers our understanding of hemodynamics. And mitral regurgitation is really a complex situation. Compared to a normal pressure volume loop, what you see is that there is a loss of the isovolumic and isovolumic contraction and isovolumic relaxation periods. More importantly, you see increases in left ventricular end diastolic volumes. And although the ejection fraction, which is measured by the width of the pressure volume loop, is increased, we have to keep in mind that it's kind of a false signal, because a lot of that blood is going backwards against the low afterload presented by the left atrium, and the forward stroke volume is actually reduced. Now, this has long-term consequences, and I apologize that this doesn't project very well, but the long-term consequences of having severe mitral regurgitation is that you have a reduction in contractility, you have profound left ventricular remodeling with significant increases in ventricular volumes, and you have a decrease in systolic blood pressure. So when you approach a patient with severe mitral regurgitation, it's kind of unreasonable to think that medical therapy alone is going to be able to increase contractility, reverse remodel the ventricle, and increase forward stroke volume. And in fact, if we look at some of the medications that are used to treat patients who have severe mitral regurgitation and heart failure, one of the best drugs we have is sacubitril/valsartan. This is data from PROVE-HF, looking at that population of patients who had moderate or severe mitral regurgitation who were treated with sacubitril/valsartan. And if we look at the degree of mitral regurgitation 6 months and a year later, still a full 50% of those patients have moderate or severe mitral regurgitation. Perhaps one of the best therapies that we have for treating functional mitral regurgitation is cardiac resynchronization therapy. Cardiac resynchronization decreases left ventricular volumes. It increases DPDT, or contractility. That then increases the closing forces on the mitral valve, and it decreases mitral regurgitation. The problem, of course, is that it's only indicated in those patients who have reduced ejection fraction, a left bundle branch block, and a very wide QRS of greater than 150 milliseconds. And this is just hemodynamically what happens when we look at pacing in patients who have heart failure with reduced ejection fraction. When you pace from the apex to the right ventricular septum, you don't see any reduction in mitral regurgitation, but when you pace from the left ventricular free wall, we see reductions in ventricular volumes. We also see a significant increase in stroke volume, and this is an acute change, again, because of restoring intraventricular synchrony and also increasing those contractile forces. So all of these recommendations are summarized then in the current valve guidelines by saying that patients who have heart failure and mitral regurgitation should be treated for heart failure, and that includes the use of a cardiac resynchronization device. In addition, in those patients who have chronic secondary mitral regurgitation and heart failure, their care really should be directed by a heart failure cardiologist that understands the structural, the hemodynamic, and the neurohormonal responses to severe mitral regurgitation. And if we turn then to the heart failure guidelines, that care is codified by saying that all patients who have heart failure with reduced ejection fraction should be treated with an ARNI, an angiotensin receptor neprilysin inhibitor like sacubitril/valsartan, combined with an evidence-based beta blocker, metoprolol, carvedilol, or bisoprolol, an MRA like spironolactone or eplerenone, and finally a class of SGLT2 inhibitors. And then we know that in those individuals who have secondary mitral regurgitation, whose care is supervised by a heart failure specialist, who continue to have severe mitral regurgitation in the setting of a reduced ejection fraction and persistent symptoms in spite of optimal medical therapy, it is reasonable to consider them for mitral valve TEER, assuming that they meet COAPT criteria. So COAPT gave us a lot of information, in particular about the treatment, the medical treatment of patients with severe mitral regurgitation. And that's because there was a eligibility screening committee that included heart failure cardiologists who really held the investigators' feet to the fire to make sure that patients were on maximally tolerated doses of guideline-directed medical therapy. And when we look at how those individuals were treated at COAPT, we see that 40% of patients, in fact, only 40%, were treated with all three classes of guideline-directed medical therapy. At the time, the SGLT2 inhibitors hadn't been approved, so the three classes of drugs were RAS antagonists, beta blockers, and MRAs. About another 40% were on two drugs, and 20% could only tolerate one drug. And when we look at the various classes, by far, the drugs that were tolerated the most were beta blockers. Almost 95% of patients were on a beta blocker, but only 2/3 were on a RAS antagonist, and only about half were on an MRA. But being on a drug is not the same as being on the targeted dose or the full dose of those drugs, which is represented here in green. And you can see that although the MRA dosing was pretty good, about 3/4 of the patients were on a full dose of spironolactone, only about 1/3 of patients were on the highest dose of a beta blocker, and only about 10% of patients were on the maximal dose of a RAS antagonist. And if we look a little bit further into those classes, about 15% were on a maximum dose of an ACE inhibitor, only about 5% were on the maximum dose of an ARB, and no one was on a full dose of an ARNI. So if patients are not able to achieve those maximal targeted doses, what then defines optimal medical therapy? And I think this is one of the reasons why I'm invited to speak at these conferences, because we really don't know what optimal medical therapy is. But I think there are some guidelines, and I can share some insights about what we as heart failure doctors, particularly those who participate on eligibility committees, look for. So number one, heart rate. Is it less than 70? That is a surrogate marker that patients are adequately beta blocked, even if they're not on a full dose of a beta blocker. Blood pressure has to be less than 130/80. Most heart failure docs will say it should be less than 120/80, but in the guidelines, that's the targeted blood pressure. There needs to be an absence of congestion, and there needs to be a low level of NT-proBNP, or relatively low, less than 1,000. And if one looks at invasive hemodynamics, having perhaps slightly elevated but not too elevated filling pressures, a right atrial pressure less than 10, a wedge less than 16, and normal flow, a cardiac index of greater than 2.4. And then lastly, and most importantly, there needs to be an absence of a decrease in GFR of more than 30%, and there needs to be an avoidance of hyperkalemia. And for us in heart failure, we tolerate potassiums up to like 5.5, 5.6, or we'll add a potassium binder to bring the potassium down. And if we put this all together, we can follow the expert consensus decision pathway that starts with patients with moderate or severe mitral regurgitation who have an ejection fraction less than 50%. If they don't need revascularization, you should initiate and intensify, or initiate and escalate all of the four classes of guideline-directed medical therapy. If there are persistent symptoms, screen them for CRT. If they're eligible, definitely put CRT in. If they're not eligible and they have ongoing heart failure symptoms, then screen them for mitral valve TEER. And if they fit COAPT criteria, go ahead and move forward with mitral valve TEER, which has a 2A recommendation. So in summary, some key takeaways: initiate and escalate all four foundational therapies for heart failure with reduced ejection fraction. Aim for those target doses, but barriers such as blood pressure, renal dysfunction, hyperkalemia, and cost are frequent and are real barriers to reaching those targeted doses. And for severe functional mitral regurgitation, those patients who are COAPT eligible, certainly think about doing mitral valve TEER. And thank you very much.